Hi, my name is Ed Shahady, and we're here at the Cardiometabolic Risk Summit in Las Vegas. And I'm here with Dr. Cheryl Landon. She's from Ventura County, Family Practice Residency. She's a medical director there. And today she's going to be talking upon cardiometabolic health and bone disease, which I found a very fascinating topic for a lot of reasons. But what are you going to tell us today?
I'm going to talk about, for instance, under recognition of altered bone quality for patients with cardiometabolic risk, and probably most typified by diabetes, obesity, but certainly that whole cardiometabolic risk profile is really underdiagnosed. More so under-recognized, let's say. If it's under-recognized, it's under-diagnosed. And I want to raise the threshold whereby we might think about it. I think we might find, if we think about it, most of the patients who are fracturing in our practice are probably our diabetics, because we've made great inroads with our other patients. And that's where the data is emerging at this point.
So what are we doing? Are we ordering bone evaluations? Are we not considering it and doing the preventive thing? Where's the lesion? What do we need to work on?
Well, we are ordering DEXAs. Certainly, bone mineral density tells us a lot about density, but it doesn't tell us about bone quality. We have a number of patients, regular patients, that we're undergoing good prevention and treatment, but diabetics in particular are probably missed, because some of the things about diabetics that appear reassuring, they may be a little bit more overweight, they may appear to have preserved bone mineral density, but it doesn't tell us about bone quality, which factors into fractures.
So how do we find out about bone quality?
Well, most of my patients won't go for that because it's a bone biopsy, but there are some other factors that are being investigated, trabecular bone score. But also we might be able to modify, and that's what I'm going to talk about, our current risk stratification tools, and take into account what we know about cardiometabolic risk, about inflammatory mediators, cytokines, and use those with a surrogate marker, let's say.
I'm always thinking of women and bone health, but do I also be thinking men?
Yes.
And men that aren't 70 yet?
Yes, so what you just brought up, we think about doing a bone mineral density at age 70 in gentlemen, but yes, absolutely, if the gentlemen that you have in your practice have diabetes, that's different than, for instance, architecture. Gentlemen, if you look at the two of us, your bone architecture, your muscle mass is different than mine. Even if you and I are the same size, there are gender differences, yes, that predispose some of us, because of architecture, to increased fractures. And in fact, in women, and there are many more women with osteoporosis, there appears to be trabecular changes, porosity changes, and that may play out.
Okay, how about prevention? Can I play it smart and just make sure they all get their calcium and vitamin D, and that'll help them out?
I think that's actually the most important. Calcium and vitamin D are the important building blocks. And if we have deficiencies, you can't make great quality bone. And what you just brought up was a super secret that I'm going to talk about, for instance. A lot of what we're talking about at this meeting is the importance of vitamin D. And it turns out that many of the patients, compared to the general population, are probably more vitamin insufficient than we originally understood.
You know, I live in Florida, the sunshine state, so you think they're getting plenty of sunshine.
They're not.
But we find plenty of people with low vitamin D levels.
Yes.
So is there any, they're diabetic, so I want to get a vitamin D level. If they're plastering themselves with sunscreen and get covered up when they go out, I want to get more vitamin D levels. Anything else should be a tip-off? They're diabetic, get more vitamin D levels?
The tip-off would be, for instance, autoimmune diseases, diabetes. Think about that. Diabetes often is considered amongst the autoimmune diseases. But also what you've described, people who work indoors. The sun, even though it shines, is at a different point in the sky. And its availability and how much of your skin is exposed. You, like myself, we're probably not wearing bikinis at the beach. So, well, I don't. So I was going to include you in my group.
You're right, you're absolutely right.
So I'm not getting enough sunscreen. I'm not getting enough sun exposure to really get it through. And that's a great place to get it, skin.
Sure.
But fortified foods can also accomplish that.
Sure. Okay. Well, I also think about diabetics. I think of certain medications that are associated with fractures, with bone mineral density. Any ones in particular that you teach about to your residents?
Yes, absolutely. The TZDs, you think about
Okay.
that. And what you just brought up is there are other risk factors that diabetics have that increase risk of falls.
Okay.
And patients who fall are more likely to fracture, and especially if they have altered bone quality. So high sugars, low sugars, too much insulin, there are other risk factors for fall.
Yeah, and if
Vision
they
changes.
Yeah, diabetic neuropathy.
Muscle. Yes.
You don't want, they've lost balance.
Correct.
So that's really worrisome with it. So a lot of issues to think about. I'm also thinking about diabetes and chronic renal disease, and that's associated with bone health.
Yes.
Anything special you want to tell us there?
So renal disease and also hyperparathyroidism
Right.
we'll often see. So yes.
Secondary or primary?
Primary and secondary.
Yeah, from the renal disease.
So renal
Yeah,
disease.
right,
Yes.
right. So interesting. Anything else you want to say about that you want to say a little bit later?
You're gonna tell me all my secrets, right?
Absolutely. No, that's great. Thank you very much.
Okay, thank
Very
you.
interesting. Good luck in your presentation.
Thank you so much.